You ready? All right, great. Thank you. So welcome, everyone. I want to make a quick announcement that this presentation is going to be live streamed, and a copy will also be made, and the copy will then be available on the website if you weren't able to come. You need to know that because some people do not want to be on film. Worry not. The camera is always on me and on the slides. So the only way you could possibly ever be identified is if you happen to ask a question or make a comment and your voice is very recognizable. Otherwise, no one will know. So you need to be aware of that, and hopefully that's okay with you. If not, just don't say anything. So, okay. Now, a couple of weeks ago, when Pastor Kurt was talking about this presentation, he mentioned that among other things, I may occasionally say something funny, and I don't necessarily plan for that. I with a joke for you then, in case I don't come up with anything else. This is a psychiatry joke, and I say I'm in my office, and I get a phone call from the front desk. The front desk person says, Dr. Hartmann, there's a guy that just showed up. He has no appointment, and he insisted on you. He said it's an emergency. So I say, well, what did he say the problem is? And she said, well, he says he's invisible. I said, well, then tell him I can't see him. So that's as good as it's going to get. Sorry. Depression, which is not funny, sad to say. Can we see the first slide? Is it? All right.
Switch.
Okay.
I got you all professionally set up. You can switch. Hey, that's the wrong one. There you go. There you go.
Here, make sure I put it on right. Okay, hopefully things will go better from here. I want to start out by talking about biology and depression because those of you who heard me in my first presentation, What is Mental Illness, know that we talk about a model of the biological, psychological, social model of illness, not just psychiatric illness. But you should know that depression, the type that we're going to be discussing here, is a biological illness as well as a psychological and social one. And so the next slide. So this is an example of evidence for that. There's an immune cell that exists in our intestinal tract that changes the gut bacteria that are always living there, and this in turn can cause depression when a person is stressed. You can see how that's a biological phenomenon. It's got nothing to do with your psychology except for the sense of being stressed. Next slide. You can leave the slides on until we do the next one. They don't need to see me. They can see me right like this. So anyway, these are scans, and it's for looking down on the brain from above. And the one on the left shows a normal scan, and the one on the right is a scan of a depressed person. All those red and yellow areas that are lit up represent actually depressed sections of the brain. And that's a biological phenomenon. That's not psychological. Next slide. Now, there are several kinds of depressive disorders that are described in the diagnostic manual. I'm only planning to talk about these first two. That's why they're in larger letters. The major depressive disorder and then peripartum depression. Next slide. Now, how do we diagnose major depressive disorder? That's the primary one I'm going to be talking about. There are psychological symptoms and there are biological symptoms, and we'll start with the psychological ones. The first one is that the person has a mood change for the negative, and that would be either depression, anxiety, or irritability. So put another way, you can have this disorder, major depressive disorder, and not feel sad, down, blue, or depressed. You may only be anxious or irritable. but often it's a combination. Both depressed and anxious, for example, is very common. And they have to be like that for most days, for most of the day, in order to fulfill the diagnosis. Because some people can feel depressed or anxious for, an hour or so, and it goes away. That's not this disorder. The second one is loss of interest or pleasure, meaning you can't get normal enjoyment out of things that you would normally enjoy doing. It's called anhedonia, which just means loss of pleasure. This is a key feature of depression, and is one of the features that helps to distinguish this major depressive disorder from, for example, just normal grieving. You can still have some happiness, interest, and pleasure when you're grieving in between the episodes of sadness. The next one is feeling worthless or having inappropriate guilt. What does inappropriate guilt mean? It means that you feel guilty about something which other people who know you would say, well, you shouldn't feel guilty about that. But individuals with depression often feel guilty about all sorts of things that they needn't be guilty about. They also may have low self-esteem and feel worthless when they're depressed, whereas they don't normally feel like that. And then they may have recurrent thoughts about death. They may have suicidal thoughts or even suicidal attempts. Next slide. These are the biological symptoms. They may have weight loss, loss of appetite, although there are people who have atypical depression where actually they eat more and gain weight. Insomnia or hypersomnia, sleeping too much, are also very common in this form of depression. Psychomotor agitation means they can't sit still, they're in constant motion, they're filled with energy, or else they feel retarded, that is to say physically, where they just sit down and they barely move at the extreme. Fatigue or loss of energy, another one, very common. And then finally, an inability to think clearly, poor concentration, or indecisiveness. Next slide. So those are the psychological and biological symptoms of major depression. And so when we see someone that comes in and say, I'm depressed or sad or I'm anxious, and we want to know whether they have that, we'll ask them about their ability to experience pleasure, to be able to look forward to things. Are they sleeping okay? What's their appetite like? Are they focusing, and so on. And if they meet enough of these criteria, then we can say, well, then you meet criteria for a major depressive disorder. Now, how common is this? It's actually the second most common disorder among the psychiatric disorders. The anxiety disorders are number one, but the depressive disorders are number two. So about 7% of people will have it in any given year. The age range from 18 to 29 is when it typically begins in a person's life. So if you're working with college students, as I did in the past, you see that a lot. They were fine, and then now they've developed this. And it's 3 times as common in that age range than it is in older people, people over the age of 60, which surprises some people. The onset usually begins in puberty through the early 20s. Now, the ratio of women to men, women have it twice as often as men do, but as we'll describe later, in childhood, the incidence between boys and girls is the same. But when girls reach menarche, the beginning of having menses, that's when it switches over to the 2-to-1 ratio. This has been studied carefully throughout the world. In every culture that they've been able to study, it's 2-to-1. And it appears to be related to the hormonal changes that begin during the menarche. Now, women are more likely than men, if they have it, to have the atypical form where they're eating too much rather than not enough, and they're oversleeping, and they may even have this kind of leaden paralysis where they feel like they basically can't move. That is uncommon in men. Not that it's common in women, but it's more common. Next slide. Now, what puts you at risk for developing a major depressive disorder? Having been depressed in the past is the most common type of risk. If you've had it before, you're more likely to have it again. If there's a positive family history, because this disorder has an inheritable component, which about 40% of the risk is based on your genetics. It's very complex genetics. Having adverse childhood experiences, or ACEs, ACE, they abbreviate that as, things like having been abused as a child, sexual abuse in particular, and I'll say as an aside, if someone has a past history of sexual abuse and they are now depressed at some time in their life, medication alone rarely works. They almost inevitably must also have talking therapy, psychotherapy. If you're a member of the sexual minorities groups, the lesbian, gay, bisexual, and so on, they have a much higher incidence of depression than the rest of the population. There are some individuals, this is more common in women, who have a personality that shows negative emotion, especially when they're stressed. Now, negative emotion would be like sadness or anxiety or irritability, things like that. If that is your personality makeup, you're more likely to develop depression. And stressful life events is a common trigger for it. So you may have these risks, but you may not have it unless something happens to trigger it. And some of those triggers may be biological events, like an illness, as we'll discuss later, but it might be losing your job or having a breakup of a relationship, might be the trigger that gets the thing rolling, and then you end up with this disorder. Next slide. Now, one of the things to be clear about is that it's not the same thing as normal grief. So when you have a breakup of an important relationship, or you lose your job, or something sad and traumatic like that occurs, you would expect to have normal grieving, and it can look a lot like this type of depression. You might not sleep well, you may not eat so much, you may have these sad spells and crying spells and the like. But this is normal, and it doesn't meet the criteria for a major depressive disorder. So I'll give you some examples of some of the differences. The person who's in normal grieving is more likely to have an empty, lonely feeling, as opposed to a full-blown depressed kind of feeling that you would see in major depression. The sadness that is experienced during normal grieving is more likely to occur in waves, where you have it and then it goes away, and then you have it and then it goes away. It's more consistent in people with a major depressive disorder. It's more constant. I already mentioned that with normal grieving, you can still experience pleasure and look forward to things and enjoy things in between these waves, whereas in a major depressive disorder, that's less likely to happen. People who are going through normal grieving don't have any negative impact on their self-esteem. They still feel about as good as themselves as they did before that happened, whereas, as we said, people with a major depressive disorder will have a loss of self-esteem. They will have this inappropriate guilt, and they won't feel as good about themselves as they normally would. And then finally, it would be unexpected that someone who's just going through normal grieving, a breakup of a relationship, that they would become suicidal or dwell on death issues. Whereas with major depressive disorder, suicidal thoughts are quite common. Fortunately, suiciding is not as common, and they may also just dwell on sort of death-related themes that runs through their mind. That's not as common in normal grieving. Now, there are some people who, in addition to their normal grieving, may have, for example, a personality disorder that then leads them to have low self-esteem and want to kill themselves. So if someone is going through normal grieving and they want to kill themselves, that is not normal, and they need attention for sure. Next slide. Now, there are a variety of biological causes that we can identify for major depressive disorder, and some of them are medical illnesses that have depression as one of their potential signs and symptoms. So next slide. So this is a partial list. There are probably 50 or more that have been shown. If you have that condition, you may well get depressed from it. If you treat the condition successfully, the depression goes away. So one of the most common ones is an underactive thyroid gland. That's that gland in the front of the throat that controls your body's metabolism. If it's underactive, if it's not producing enough of the thyroid hormone, you may well become depressed. That could be one of your symptoms. Parkinson's disease is another one. Seizures, diabetes, they're a long laundry list. Next slide. Depression can also be the side effect from a medication. We'll show you some examples. Next slide. Oddly enough, birth control pills is a common one, and there are a lot of young women who started on the pill and they become depressed and wonder why. So if you have a patient and they're on birth control pills, especially if they just recently started them and they become depressed, you have to think about, well, maybe that's the reason for the depression. Another one is interferon alpha. I'm sure you've all heard of that. I'm sure not. It's mostly has been used to treat hepatitis C, but it's also used for certain immune disorders like multiple sclerosis, and it's used for some cancers like non-Hodgkin's lymphoma. Well, it causes depression a lot of the time. So in fact, I used to do a lot of consults from gastroenterologists, GI doctors who would refer patients to me because they wanted to start them on interferon alpha, and the incidence of depression was so high. They felt they needed a psychiatric evaluation before they would start them on the medicine, and that if it did happen and they still needed the medicine, that I would be available to treat them. So those are just examples. There are a large number of medications that do that. This is one reason why it's a good idea if you become depressed to not only see a therapist, but to also see your family doctor and or a psychiatrist, because you need to make sure that the reason for it is not that you started on a medicine that's causing it, and therefore you need a change in the medicine, and that takes care of the depression, rather than just going in therapy and talking about things. So there are biological causes, and that's in the bailiwick of the medical profession and not the therapists. They play an incredibly important role, but it's not this part of it. Okay, the next slide. There are also addicting substances that can cause depression. You see at the very top, number one I've listed is alcohol in big letters because that's overwhelmingly the most common one that does it. So people who drink alcohol to excess often experience depression as a side effect of their drinking. So when I see a patient who's, for example, using alcohol to excess and they're depressed, I have to figure out, are they depressed because of the alcohol, because it certainly can be the case, or are they unlucky enough that they're both depressed and they have an alcohol use disorder? And the only way you can really know is, number one, if they've had episodes of depression before they ever started drinking, now they're drinking and they're depressed, well, then maybe it's the alcohol. The other way is if you can get them to stop drinking for a month or more and the depression goes away without doing anything else, then you know the alcohol was the culprit. So absolutely, these substances that you see listed and many others, as one of its manifestations, can be creating a major depressive episode. So the treatment there is not just to give them antidepressants, it's to get them off of their substance use. Next slide. Sort of another reason to have a physician involved early on in the assessment of someone with new depression. So drug addiction and depression goes in both directions. So you can become depressed because of alcohol or cocaine use or whatever. On the other hand, people who are using these substances, perhaps because of what effect it has on their lives and other factors, may then become depressed. So 16.5% of people with an alcohol use disorder, that's the modern terminology for what we used to call alcoholism, they have a major depressive episode that goes on. And 18% of those with a substance use disorder, meaning substances other than alcohol, such as marijuana or cocaine, amphetamines, what have you. So depression plus addiction leads to a 25% increase in the risk of suicide. A majority of people who suicide, there's alcohol on board their system when they've done it. So it's a bad combination. It's called dual diagnosis when you have a substance use disorder plus a psychiatric disorder like depression or anxiety. Next slide. Now, what about children? I can realize this is hard to see, but so I'll tell you what it's talking about. Essentially, children can get depressed. A lot of people are surprised that as young as age 3, they can have a major depressive disorder. And the younger you are when you have an onset of major depression, the worse it tends to be. an increased incidence of suicide, for example, the ages of 3 and 6. Now, children won't necessarily present exactly the same way an adolescent or an adult will. They can't always articulate exactly what they're feeling, so they may act it out, they may start misbehaving and that sort of thing. So that needs somebody with some expertise in assessing children and adolescents with mental disorders. They have primarily 3 of them. The one that we've been talking about is major depressive disorder, but they also have something that's been called dysthymia. A new name is persistent depressive disorder. It's a milder form of depression, but it goes on for very long periods of time, and it often shows up more as irritability than it does either sadness or anxiety. Now, it's particularly true in children. And they also have something called the mood dysregulation disorder, where they have these rage episodes. It's almost like a bipolar disorder in children. So these 3 are often the way it shows up in children and then in adolescents. Next slide. Depressed children tend to have more anxiety and psychosomatic symptoms, stomach aches, headaches, that sort of thing. And unfortunately, the diagnosis is often not made because people don't expect children to be depressed, or they don't recognize this anxious, irritable, acting out child. They don't think about, well, that could be depression causing it, but it certainly can be. So on average, it takes almost 13 years before a diagnosis is made, and by then the problem has gone on a bit too long. Suicide attempts increased 22% during the pandemic, to show you some of the harms that come from the pandemic. And it probably had to do with changes in their socialization. They weren't interacting with other kids. They weren't going to school and that sort of thing. Next slide. Before I leave that entirely, I will say that suicide is the 2nd leading cause of preventable death in children and adolescents. 6-year-olds do commit suicide, and luckily not very often. As that thing had said, only around 0.7% or 1%, 1.7% of kids can have depression. We're talking now about major depressive disorder, but unfortunately, when they have it, there are some significant risks. And by the way, that's the same incidence of autism spectrum disorder, for example. So it's not as rare as that may feel. Okay, now we're going to talk about peripartum depression. That was the second one I was going to emphasize. Peripartum means around the time of giving birth. So it can be before that, so before they get pregnant, while they're pregnant, or after the delivery, and according to the rules in the diagnostic manual, for up to a year afterwards, although their risks can actually go on beyond that. But this is called peripartum, meaning around the time of delivery. Next slide. 1 in every 7 pregnant women will have a peripartum depression. It's pretty serious because some of them suicide. They may have problems bonding with their child. They're going to have even worse trouble with sleep and appetite and so on. About 1/3 of them have comorbid psychiatric disorders, meaning they not only have this depression, but they may also have an anxiety disorder or some other psychiatric disorder. Of the women who get screening, and now obstetrician gynecologists are very much into doing the formal screening for this, 75% of them who positively screen, meaning they have evidence that they have it, never get any treatment. So you kind of wonder, why are we doing all this screening if we don't send them on for treatment? They really need it. And it's a very serious condition. Now, if someone has a positive screen, and so it appears they have depression during pregnancy or after in particular, there are certain lab tests that should be done because they can contribute to it. And an example of that, testing them for anemia. They may have had some significant blood loss. That can contribute to the depression. Or they may have an underactive thyroid, as we mentioned, and that may be fully the cause of the depression. So you don't want to miss those, because those are treated very differently than someone without that happening. Now, the preferred treatment, if they are pregnant or if they are breastfeeding, is to use one of the talking therapies, psychotherapy. And ones that's highly recommended is called interpersonal psychotherapy, and I'll describe what that is later on in the presentation. And they may or may not also need medications. Now, I will say that I have seen over the years a number of women who are on birth control pills. Well, they may have been on birth control pills, but now they got depressed and they're on an antidepressant, and lo and behold, they get pregnant. And now everybody panics and they take them right off of their medicine, and then they go through this vicious withdrawal syndrome, which is very hard on them. And I would end up seeing them. Part of that's because having been trained in family medicine where I did obstetrics, and then also in psychiatry, I feel comfortable dealing with the psychiatric illnesses in pregnant women, and I know what you can safely do and not do. And one of the first things I do is put them right back on their medicines, because the risk from untreated depression is much higher than any possible risks to the woman or the developing fetus from the medication. The medications we can use during pregnancy are actually very safe. Not that there are no risks at all, but they're generally very, very safe. So just so you're aware of that. Now, there is a new type of medication, new meaning within the last decade or so, that's very specific for postpartum depression. The woman who's developed depression soon after the birth of the baby. And the first one was called brexanolone. It's a derivative of one of the female hormones, and has a very interesting mechanism of action. The problem was it has to be given intravenously. It has enough side effects that the woman has to stay in the hospital for 3 days and be carefully observed by the nursing staff. But it is highly effective and can turn around the depression within 3 days. That's sort of unheard of in most forms of depression. So that's quite a good advancement in our healthcare armamentarium. The problem is that the medication alone costs $34,000, and a lot of insurance companies are not interested in paying that. So it's not as available as one might hope. And part of that's because they have to stay in the hospital. So the pharmacochemists got together and they said, isn't there a way we could provide an oral form? They can just take a pill. And fortunately, they came up with that, and that's called zuranolone. And it's a pill you just take twice a day for 14 days. Now, it doesn't turn things around in 3 days, as the intravenous one does, but it does in about a week. And it's a dramatic shift, and they take it for another week, and that's it. It's absolutely amazing. We don't normally see that in treating major depressive disorder. Now, the problem is the pills aren't cheap either. They're around $15,000 for a 2-week trial of those medications. You need to have a prescribing physician, and yes, you have to see them on a regular basis throughout, because there are some side effects from it, including some dizziness, some mental confusion may occur. And so women are not supposed to drive or operate heavy equipment, that sort of thing, while they're taking it. But again, it's something that the insurance companies, many of them, will not pay for, and there are not a lot of women who have 15,000 grand around where they can pay for the pills themselves. Next slide. Oh, as an aside, I wasn't going to talk much about this, but I just want to say that for postpartum depression, the depression that occurs after the baby's born, some of those individuals, unfortunately, develop a psychotic form of depression where they may be hallucinating or delusional. Usually when you hear about a woman who's given birth and ends up killing the baby, it's usually because she has developed a postpartum depression that is of a psychotic nature. And most of the time, that's not a major depressive disorder. It's bipolar disorder depression, which we weren't talking about, but that is more likely to cause a psychotic thing. So what could happen, for example, the woman may have delusions that the baby has been adversely affected by a devil who wants to take over the baby's soul. And the only way the mother can save the baby's soul from going to hell is to kill the baby, so the baby's soul will go to heaven right away. And that's why they're killing the baby. It's not they don't like their babies or anything. And unfortunately, these women end up in the legal system and go to jail. They don't get treatment necessarily. So I think that's tragic. Okay. So this next one has to do with treatment options. So if someone has a major depressive disorder, what can we do for them? Well, there's a large number of antidepressant medications that we can use. There are at least 9 different categories, and within each category there are usually several different options. So you're talking about 45 or 50 different medications. So it's not an easy thing to decide when to use what and how you use it. But since there are nowhere near enough psychiatrists, most of these patients' initial treatments are begun by family doctors, obstetricians, and others, and that's perfectly fine. Hopefully they've had enough training to recognize you're dealing with major depressive disorder, and they have some sense of some of the basic medicines that you would start with. And it's when that doesn't work, or they become suicidal, then that's when it's appropriate to bring in a psychiatrist. We have to learn all that stuff, thanks. Anyway, so there are a whole bunch of them. A number of them are approved by the FDA, and so they're usually covered by insurance. All of them tend to work by increasing the availability of certain neurochemicals that enable one nerve to communicate with the other nerves. And so they help them to be released and or then to attach to the other nerve, and that's how they communicate with each other, is by releasing these chemicals across a little gap between them. And these medications make them more available. And the thought is that perhaps in major depressive disorder they don't have enough of them, or they're not attaching properly or whatever. Now, it's not simply a matter that these chemicals then become available and they will signal from one nerve to the next. That happens within hours of taking the pill. But because they become attached to the other nerve, that sends along some secondary processes that end up changing the genetic expression in the nerve. And that takes usually a couple of weeks to start. That's why when you're given an antidepressant, your doctor would normally warn you, you're not going to feel any better for a couple of weeks. It takes that long to start working, and sometimes it takes longer. So that's something that's helpful to know about that. There are a couple of new antidepressants. They each have their purpose. One is called gepirone, and it is basically like some of the older antidepressants that deal with a particular chemical called serotonin. A good example of that is Lexapro, but it's a different chemical. It works on a different serotonin receptor, and as a result of that, there are fewer sexual side effects, which is one of the problems with a lot of these other antidepressants. So that's why it has been released in the market. The other one is unique, and that's called Auvelity. It's extended release. It has 2 older medications that are put together in one new pill. So there's no new chemicals in it. They're just two things that have been around a long time that are put together. One of them is a well-known antidepressant called bupropion. Wellbutrin is the trade name. That's highly effective. But in addition to that, they add to the mix dextromethorphan. Dextromethorphan has been used almost exclusively as a cough medicine. So when you buy Robitussin DM, the DM stands for dextromethorphan, and it's to reduce the risk of coughing. It has an interesting mechanism. Well, it turns out that mechanism includes an action on a particular type of nerve receptor called the NMDA receptor. And that turns out to be helpful for depression. And the chemists who figured that out said, gee, can't we mix that with this other one to make them both be stronger but don't need high enough doses of either one to cause a lot of side effects? And it turns out it is actually quite effective, and it starts rapidly, usually within a week. Unlike the rest of them, it takes 2 weeks or more to start working. So that's its best advantage. And since the ingredients are ingredients that have been around forever, it's not that expensive. Usually when you have a new medication, it's going to be very expensive. Now, I'm sure the pharmaceutical company has figured out a way to get more money by doing this, but it shouldn't be that much more expensive. Now, there are some over-the-counter treatments that are not FDA approved that can be helpful for people with depression if, for whatever reason, they cannot or do not want to take one of these FDA medications. One that's been around a very long time is called St. John's wort, W-O-R-T, not a wart like a wart on your finger. It's actually a derivative from a mushroom, and it actually operates on those same chemicals that are signal chemicals from one nerve to the next, as with the FDA-approved medications, but they're in varying doses, and it's called a dirty medicine, meaning it's mixed with a whole bunch of stuff that doesn't even need to be there. It's not overseen by the FDA, so you don't know for certain if you're getting the right dose or not when you get it. But a number of people have found benefit, but only for mild to moderate forms of major depression. But it is an option. The biggest challenge with it is that it has a lot of interactions that are not good with other medications. For example, a woman on birth control pills should not take it. It makes the birth control ineffective. That's not a good idea. If you are going to take it, you take a 300 milligram pill 3 times a day, though you can take up to double that amount. It's something you buy over the counter. Another one is magnesium. It's just an ordinary elemental chemical, but it's very important in bodily functioning, including your nervous system, the brain, and your peripheral nerves as well. And it turns out that it affects a particular receptor called the NMDA receptor, and that's one that you might know of because that's involved with the street drug ecstasy or Molly, a bunch of other names. It acts as a hallucinogen, and it's very excitatory. It relieves people's inhibitions. And so sometimes it's used for parties, so people would get disinhibited and do things they wouldn't otherwise do. Well, that same receptor, if it's given the proper dosing and so on, rather than a street drug, it turns out can actually help depression. Now, you ideally would want to know whether your magnesium levels are low in that situation, and therefore maybe you need it anyhow. But there's unfortunately not a great correlation between the blood levels and the levels in the brain. So it might be just something that you would just try. And again, you can buy magnesium over the counter. And that's 125 to 300 milligrams a day. And the last one like this that I'll mention is NAC or N-acetylcysteine. It's a chemical that you can get, again, over the counter. You can get it from Amazon. You can get it from your pharmacies, what have you. You take about 800 milligrams at 2,000 milligrams a day. But it only works if the person has elevated inflammation in their body, and particularly in the brain. About a third of the people who have major depression have inflammatory process going on in their brains. And the way you can tell that, there's fortunately a blood test you can do called the CRP, the C-reactive protein. Is produced by the liver when there's inflammation in the body. And if it is elevated over the level 3, then this medication over the counter may work. If it's not over 3, it will not do anything for you. So you probably would want to see your family doctor. Someone say, hey, can I get a CRP test to see if I have inflammation because I want to try this medicine for my depression. All right, so that's a bit about the medications. Now, there's another thing that's recommended for anyone with depression. It's called behavioral activation. And basically what you're encouraging them to do is to do activities that they normally enjoyed. If they liked gardening, work in the garden. If they like going to the gym, go to the gym. Do things that you normally enjoyed. And what you'll find is you would imagine, I'm not going to enjoy it. Remember that anhedonia, the loss of pleasure. But it turns out people actually end up enjoying it more than they thought they would, and it helps relieve the depression to some extent. Encourage exercise 30 minutes a day. Get about 7 hours of sleep a night. Proper diet, like the Mediterranean diet, is a good option. And so exposure to sunlight, which is a great option here in Florida for most of the year. Getting out into nature, going out in the woods, what have you. And then learning and using mindfulness are all components of behavioral activation, which is something that every depressed patient should have, whether they're on medicines, getting therapy, whatever. This should be done as well. And then there's the talking therapies, the psychotherapy. I'm going to talk a little bit about 2 of them. One is the one I mentioned before, and that's the interpersonal psychotherapy. But also about the most common one is called cognitive behavioral therapy, and I want to let you know a little bit about that. And then there are a couple of the pure biological treatments, One is transcranial magnetic stimulation, where a magnetic force is placed against the head. It's done as an outpatient, doesn't require anesthesia. And the other one is electroconvulsive therapy, which is an electrical current is placed through. You have to be anesthetized for that. Next slide. So the talking therapies are very, very powerful, and people don't realize all that they do. They say, well, you're just talking to someone. How does that help this biological condition? It actually literally changes the brain. And the talking can do that, it turns out. And people say, how can that be? Well, one of the examples I give is I said, imagine if those of you sitting here, someone walked in, a police officer said, say, excuse me, but there's someone with a Chevy outside in the parking lot, whatever, and I just want you to know that a truck accidentally ran into it and it's totaled, so please, if you're the driver, please come on out. If you were the person who owned that car, I can promise you that your heart rate would be elevated, your blood pressure would be elevated, your skin galvanic measurements would change, and so on. All that happened because somebody used words with you. How does that happen? So there it does, and actually we can measure some of the changes that occur when therapy is done correctly. There are lots of different types, and some of it's a matter of what training the person had, but also what type of condition they're trying to treat. And there are probably 10 or 12 or more different types of psychotherapy. It is often the case that if you have a relatively severe form of depression, if you get therapy, which is a great idea, you probably also need medication, so they can go together. And there's something new that's going on, or it's old and new. It was done in the 60s, but it wasn't done with the same level of rigorous research that's going on now, and that's using psychedelics. The most common one is psilocybin. It's a hallucinogen. It's been used and abused over the years, but it turns out it's actually very powerful in helping people to overcome depression. In Germany, there's a requirement that only psychiatrists with specialized training in therapy can prescribe this medication, and they must do therapy with the patient. So it's psychotherapy plus psilocybin. And it turns out that for a lot of patients with major depressive disorder, the depression starts to lift after just one episode. So it's a very powerful treatment. We're doing a lot of research on it now in the U.S. Someone in a previous episode told me, well, this was researched back in the 60s, and that's true. The challenge was it wasn't being researched with the same type of rigor that is now required for it to be approved by the FDA. You need exact amounts. If you say, I'm giving 30 milligrams, it has to be 30, not 29, not 32. It has to be purified. You can't have a bunch of extra stuff in it. It has to be given at certain intervals, certain things you have to watch for and the like. And it wasn't done at that level back in the 60s. But it is being done now. Johns Hopkins is one of the places doing a lot of that, and they were doing it when I was there. And they have a big program, and I'm very confident that this is going to be a big part of treatment going forward. And then lifestyle changes are also often recommended as part of therapy, and that includes the brain activation that we discussed. So the next slide. So the cognitive behavioral therapy is currently the most common form of psychotherapy that's done for anxiety and depression and a lot of other conditions. It's highly effective, and it's based on this notion that the way in which we feel, our emotional state, is affected strongly by what we're thinking. Our cognitions or thoughts determine how we feel. And depressed people tend to have more negative thoughts than people who are not prone to depression. And so these negative thoughts keep driving their negative emotion. And the reason why they seem to have more is because they have certain underlying beliefs or schemas, they're called technically, that were developed in childhood that lead them to have negative thoughts. So I'll give you an example. Imagine that you're a young girl, and in your family, both of your parents blame you every time something bad ever happens. A vase is broken. Why did you do that? It was actually the cat that broke it, but you get blamed. That happens all the time. Now, you're just a kid. You have concrete thinking. You don't sort this out. You begin to think that if something bad happens, it's my fault. That then becomes an underlying belief. Now, you don't know that's your belief, but that's just what is underneath. So now imagine you're now 22 years old and you got pregnant, you're all excited and happy, but you have a miscarriage. What are you going to think? What did I do to cause it? Like, because something bad happens, it's my fault. What did I do? Oh, I missed that one prenatal vitamin that one day. Well, that can't cause a miscarriage, but you don't know that. So you're thinking, so next thing you know, you're starting to feel down on yourself, sad, anxious, what have you. So that's an example of an underlying belief leading to negative thoughts that lead to negative emotions. So these therapists are trained in helping you to recognize what are your negative thoughts, and there are techniques for coping with them. So an example might be something called catastrophizing, or making mountains out of molehills. So something small happens, and then you magnify it as if it's something much bigger than it really is. Gee, I got a B+ on that exam, and I wanted to get an A+. It must mean I'm probably going to fail the course. I'm really more stupid than I think I am. I'm never going to get into nursing school that I hoped I would, and on it would go. That series of thoughts is going to lead you to feeling pretty badly, right? So what a therapist would have you do is recognize that that's what you do. You tend to have negative thoughts about yourself, the world, and the future, and what you can do about it. So one example of what they say is, well, when you have a thought like, oh, I'm going to fail because I only got a B+, why you think you'd fail from that, but is to say, I'm having the thought that I will fail. In other words, realize this is just a thought. It's not a rational statement of fact, okay? So that's just one kind of small example. There are all techniques that they use to deal with them. It can be very effective. Next slide. It turns out there are some computer programs that use cognitive behavioral therapy so that you don't even have to have a therapist necessarily. It surprises a lot of people. It can be highly effective. Next slide. So these are online apps, ages 18 and older, and it can significantly reduce depressive symptoms, although mainly, again, in mild to moderate cases. And it turned out, whether in the research, if they had a professional that was kind of helping with that versus just doing it on their own, it didn't seem to make any difference. So it worked out better if you reward someone for participating. And it takes up to 8 weeks, but if you spend more than 8 weeks doing it, it's actually less effective. That's interesting. So it's called Behavioral Activation Plus Cognitive Behavioral Therapy. So it's an option for people who are out in rural areas, they don't have access to a therapist, or they don't have money for the therapy. They can try one of these online apps. Next slide. Now, the other one that we talked about is interpersonal psychotherapy, which has been recommended particularly for postpartum depression. Postpartum depression is because the woman now has a baby, or maybe she developed it even before the baby was born. If possible, we'd prefer to use just talking therapies rather than medications, because talking therapies rarely have any negative side effects. So if it's available, that's what's being recommended. So interpersonal psychotherapy doesn't say that your relationships cause depression, but the depression is occurring within the context of relationships. And in the case of a woman who's just given baby, there's a relationship with the baby and a relationship with the baby's father and so on. And these are often drivers of the depression, which is really biological to start with, but the psychological and social factors help to contribute to its severity and continuance. And what the IPT therapists have discovered is that there are 4 types of categories of relationships that need attention. And so the focus in the therapy session is on your nature of your relationships. And these are short-term therapies, maybe 12 sessions, an hour once a week. So one of them is having disputes or conflicts with others in your life. It might be, your spouse you're having arguments with, or conflicts over things. Another one is role transition. That's having a baby is a transition for you. Even if you had a baby before, maybe now you have an older child plus a baby. That never happened to you before. Maybe you lost your job. Maybe you developed a serious illness. Some kind of transition in life, some change in your life circumstances. That often is a significant one. There is a saying in psychology that all change is a loss, even good changes. In other words, if you get a promotion on your job, so now you're a manager and you're going to make more money and you have more authority, isn't that wonderful? Yeah, but you may also get depressed. Well, why is that? Well, you've never been a manager before. Are you going to do a decent job? Or are you going to screw up and end up getting fired? Are your fellow employees that you used to work with, are they going to start hating you because you got promoted and they didn't, and so on? It's a change, and every change is loss, even positive changes. And so any sort of change in your life circumstance can be a driver for depression. The third one is bereavement. That's the death of a loved one, and that can be the trigger. Now, normally you would expect to have normal grieving, and that's the most common outcome, but some people who have genetic and other vulnerabilities to depression may develop a major depressive disorder, and there are techniques for helping them. And then the last one is called interpersonal deficits. Basically, they're not very good at relationships. And that's the hardest one to treat because the therapist has to work with them to overcome whatever is the barrier to them being able to relate well to others. And it might be based on their personality. Maybe they're very dependent. Maybe they're hostile. Maybe they don't know how to communicate. Maybe bad things happen to them in relationships in the past that have kind of soured them. And so therapists have to discover what their past history is like and what are their patterns of behavior and that sort of thing. So it can be very powerful. Well-researched. It was developed specifically for major depressive disorder and seems to work pretty well for postpartum depression patients. Next slide. So these are just pictures of the person on the left is getting ECG. It's the electric current passed. You can see the electrodes on the head just to look for the seizure activity that occurs. There's nothing you can see in the body because they get a muscle relaxant. It's incredibly safe. It's very powerful. And it's the treatment of choice for someone with a major depressive disorder with psychotic features. They're hallucinating, delusional, or just so severe they're non-functional, very suicidal. I can say if I ever got a psychotic depression, I would want that treatment. The other one on the right is transcranial magnetic stimulation. That's where you can see they put a big magnet next to the head and the magnetic flux is used, and that sort of resets the brain. And it can be a very powerful treatment for major depression. It's done as an outpatient, doesn't require anesthesia. It's just not quite as powerful as ECT. Next slide. So now I'm going to open up for questions or comments if you have any. The only request I have is that the questions have to be easy ones, okay? No hard ones. And then the next slide we'll leave on. Go ahead, put the next slide on. I do a blog typically once a week. It's on healthcare topics, not just psychiatric ones. A lot of them are medical ones. If you're interested in they're usually 1 or 2 minute reads, that's how you can access it, phartmo1.wordpress.com. So with that, questions or comments, and there's a microphone available. Here he is, Mark. Here. All right. Okay, the microphone wasn't on. But I did hear you, so I'll just repeat it for you. You want to know the difference between introvert and extrovert and depression?
Introvert, is there a difference in depression, or do they both behave the same way?
Okay. So you want to know whether there's a difference in behavior in people who are introverted or extroverted and how they respond to depression. I don't know of any difference in how. Obviously, there are differences between introverts and extroverts. I'm a classic introvert. Extroverts tend to gain energy from their interaction with other people, and they get testy and angry and upset if they don't get to be with other people. Introverts lose the energy by doing it, and they need to go and be by themselves and regain their energy level. So there might be some difference in what they'll say or express about their depression. Maybe the extrovert might complain more, for example, but there's no actual difference in the depression. Mm-hmm. Mm-hmm.
Pretty loud. I don't think I necessarily.
I would like to use it anyway.
Okay.
That way we have to set a precedent.
That one.
Yep.
So similarly, the one on the left that's supposed to be normal has no activity on the right hemisphere, equal, but then is that still considered normal? Why shouldn't there be yellow spots on the right side?
Well, the one on the right is the depressed side.
No, I'm sorry. On the left that's normal, there's no other activity on the right hemisphere?
Oh, you're talking about the difference in the hemispheres in this particular case.
That one,
Yeah,
correct.
yes.
So
Yeah, go
shouldn't
ahead.
there be?
Well, the slides don't, the scans, this particular type of scan doesn't always just show it on the one side, on the left side. It may show it on the right side in normal people. You might have some yellow on both sides. It depends on which side of the brain is quieted down compared to the other side.
So
And
that's
in
if
this
you're-
particular case, it's mostly what you should just be paying attention to is not the location so much as the volume of in the difference.
So if
Yeah.
you're a right side thinker, it could be
Yeah,
at
either the right or
rest.
the left side.
But
I mean,
then,
they do have some different functions with a lot of overlap, so it sort of depends on what they're doing when the scan is done.
is there similarities between this depressed on the right, where you see these advertisements for Alzheimer's? Is there, with the activity with Alzheimer's, it seems like it's all a lot of activity with Alzheimer's or the decline of the brain.
Yeah. So
Similar
in Alzheimer's, yeah, those scans, or they're a different kind of scan. PET scans are used primarily for Alzheimer's disease. That they're scans, but they're different. But they are very diffuse because that disease is very diffuse in the brain.
But are there similarities considered to be similarities?
Between that and the depression, not in terms of the scans. No,
Okay.
they're different. Yeah.
I don't know if this relates to your presentation, and I'm thinking that it does, but I'm in communication often with a person that says that they Baker Act themselves regularly because they get depressed, they're bipolar, they have psychotic issues going on. Where would that kind of, how could this person get help knowing this and continuing to Baker Act themselves?
You're wondering why don't they follow the treatments that they're supposed to, so they don't
And
have to
can
keep
they
getting
get
back
help?
in the
Because
hospital?
this is continuously
Yeah.
happening.
Yeah, unfortunately, not following through with treatments that are recommended is quite common, and more so in mental illness. And some of that's because, for example, people with schizophrenia, the medications they require tend to cause a lot of side effects that are very uncomfortable, and they don't like it. But the other thing that happens is if you have somebody who's bipolar or has schizophrenia or depression, when they start to feel better, they say to themselves, oh, I'm better, so I don't need this anymore. They don't make the connection, well, the reason you feel better is because you're taking it, and that you need to stay on it or else you're going to get a relapse and you're going to have it again. But there's this psychological mechanism we have called denial, where we act as if in our mind as if this is what's really happening isn't really happening, and it's unfortunately very common among humans to do that. So they go in denial about what it's doing. And I will say it's true that there are serious side effects with the antipsychotics that are used for schizophrenia, for example, and sometimes in bipolar disorder have them. So any excuse that they can come up with in their own minds to stop taking it. So the most common reason why some schizophrenia ends up being rehospitalized is from not taking their medications. A second reason is if environment where there's high levels of expressed emotion, negative emotions, like there's a lot of anger going on in the household or something like that. Those are the main reasons for relapse. And it's a universal problem in our field, unfortunately. But that does happen in general medicine too, where people say, hey, I'm taking this medicine for my hypertension, my pressures have been great for a while, I'll just stop taking it because I don't like to have to take medicine. And the next thing you know, their pressures are way up here.
And let's say the person takes the medication, and then they're released from the place where they're housed, where they're pretty much made to take the medication.
Yeah.
What happens if they are unemployed and they need the medication but can't afford it? because they can't pay for it. Are there sources out there for somebody like that?
There are some resources like that. For example, medical assistance should cover those medications. And there are some other programs available, like in this area very near to here is EVRA, which is a government-sponsored program. You know about that? Yeah,
Yes.
right across the way.
It is.
They have both medical people. They now have, I think she told me, 4 psychiatrists there, and they have therapists there. And the building next to it is all for dental work. And because it's government-sponsored and underwritten, you only have to pay what you can afford to pay, which may be nothing. So those are some of the options that you have. In terms of the compliance piece of it, we now have injectable forms of antipsychotics that can last for up to a month or so. If the person gets their shot, then you don't have to worry about them taking anything for another month, but they got to come back in a month. That's the challenge. So,
Got it. Thank you.
yep, sure.
I may have missed it. Is stress a trigger at all?
Absolutely, yes. So any number of stressors can be the thing that pushes you over the edge, and then you get clinical depression.
And you just, that leads to even more stress.
Yes, that's right. So stress can cause more stress. I've actually been thinking that dealing with stress should be one of my next talks. It's a very common problem, and fortunately there are things you can do about it. But anything else? Yes.
Would you be able to repeat the over-the-counter? Because I know someone that, and they don't have the insurance, but they're actually going through Avera, but they don't really want to be on the regular medications.
Mm-hmm.
So I got the magnesium, but if you could,
Yeah, so
The
the
other
other
ones?
two, one was St. John's wort, W-O-R-T, and the other one is NAC, N-acetylcysteine. You just have to remember NAC. You don't have to remember the chemical name. And that's the one where you have to have an elevated C-reactive protein as evidence that you have an inflammation going on. It has to be above the level of 3 for it to work.
Does a normal CT scan show evidence of depression like we saw on the screen? Or is
No,
it-
CT scans will not
They
show it, nor will an MRI. You need special scans.
Oh, thank you.
And those scans, by the way, are not available for just regular clinical use. You know, you see a patient say, I wonder if they're depressed, I'll get that scan. No, it's for research. No, the ones you saw, those are research scans, yeah.
What kind of scans are they?
Which agent do they use? I don't know.
The actual test itself. What is it called when you're seeing that? When you
Well-
put that up there,
Yeah,
you know it's a PET scan or this.
yeah, no,
scan.
it's a research scan, so I don't know that it has, I mean, it has a special technical name, but wouldn't mean anything, so, yeah. There's none that I could order, for example, from someone. We are developing some tests nowadays that we can do, like to distinguish bipolar disorder, which is where they get depressed but also manic or hypomanic. Distinguish that from just depression that's a major depressive disorder. There's now a chemical that's found at higher levels in the blood of people with bipolar disorder. So if that pans out, we might be able to order one of those and distinguish them. It's very important because the treatments are dramatically different.
The difference between ECT versus EST, with the ECT tests, is there loss of memory with that, even though it gets everything lined up again? Is there loss of memory versus an EST test? Where I heard you
versus the
lose a month or
TMS
so.
you're talking about.
Yeah, the electronic shock, yeah.
So with ECT, there is some memory loss, and it's for the recent memory only. So you remember who you are and where you grew up and what your wife's name is, but you may not remember what you had for breakfast. Is that sort of difference? And that's only temporary. Yeah.
Are they using ketamine IV for major depressive disorder?
Okay, yeah. So ketamine is another option, one of the other medications. I couldn't discuss all 50 or so. But it's actually very, very powerful. And it was initially given intravenously Ketamine has been used in animals for a long time as a tranquilizer, but it turns out it works on that NMDA receptor that I mentioned before, and it's very powerful and can relieve depressive symptoms within hours, actually. Well, IV treatments, that's a big deal. So fortunately, there's now a version that's given through the nose, an intranasal spray. It gives you the same medication that's been modified from ketamine to S-ketamine, ketamine. And it doesn't work as fast, it's not as powerful, but doesn't require intravenous medication. So it can be very powerful. But because of cost and other factors, we're really only using it on people with severe depression that does not respond to other treatments, so-called treatment-resistant depression. That's what it's supposed to be reserved for. Okay, well, we've run over 5 minutes. My apologies. But I will stay here afterwards if somebody just wants to come up just to ask a question since we've ended. And with that, thank you all for your attention.